Hello everybody. Our topic is going to be tumor markers. So we'll be discussing all important tumor markers needed for your board exams. What are tumor markers? Tumor markers are substances that can be detected in higher than normal amounts in serum, urine, or tissues of the patients with certain types of cancer. They can be produced by cancer cells or by other cells in the body in response to the cancer. They are usually detected by using immunoassays. What are the uses of the tumor markers? Tumor markers can also be found in other benign conditions, including benign conditions. For that reason, you can't use them as diagnostic markers. Since they can be found in other conditions, including benign conditions, a positive result must always be confirmed by other test methods, maybe by imaging or biopsy and histology. So we have to confirm tumor marker result by a confirmatory test. But you can use tumor markers as screening markers or prognostic markers or predictive markers. Screening markers are used for initial identification of patients with the disease. So if there is a possible diagnosis, you can use screening markers for the initial identification. Prognostic markers are used to predict the disease-specific survival about the prognosis. Predictive markers are used to predict the response to different treatment modalities, response to surgery, response to chemotherapy, response to radiation, like that. So we'll talk about some common tumor markers. CA19-9, carcinoma antigen 19-9, is commonly used as a tumor marker in advanced pancreatic cancer. It is also elevated in 90% of patients with biliary tract carcinoma, maybe intrahepatic or extrahepatic. Carcinoma antigen 15T, CA15-3, most useful in following the response to treatment in advanced breast cancer. It has high sensitivity in the metastatic disease. It can also be elevated in cancers of lung, ovary, gastrointestinal tract, and endometrium. It may also be elevated in benign conditions such as hepatitis, pelvic inflammatory disease, sarcoidosis, pregnancy, and systemic lupus erythematosus. Carcinoma antigen 125, CA125, is elevated in 80% of epithelial ovarian cancers. So it is used to assess the success of treatment and monitor the recurrence of epithelial ovarian cancers, because the epithelial ovarian cancers are the most common ovarian cancer, which account for 90% of ovarian cancers. It is also elevated in fallopian tube cancer, endometrial cancer, endocervical cancer. Can also be elevated in non-gynecologic cancers, pancreatic cancer, lung cancer, breast cancer, and colon cancer. May also be elevated in benign conditions, normal or ectopic pregnancy, endometriosis, fibroids, pelvic inflammatory disease, pancreatitis, and cirrhosis. CA27-29, carcinoma antigen 27-29, elevated in breast cancer. So it has a very high positive predictive value and very high negative predictive value, I mean close to 90% in detecting breast cancer recurrences. So it can also be elevated in cancers of stomach, colon, kidney, lung, pancreas, and liver. Also elevated in benign conditions such as endometriosis, kidney disease, and liver disease. Carcinoma embryonic antigen CEA is a glycoprotein found in the embryonic endodermal epithelium. It's elevated in patients with primary colorectal cancer. So it is the marker of choice. It is the best marker in assessing metastatic colorectal cancer after therapy. So the current recommendation is to measure carcinoma embryonic antigen levels every 3 months for at least 3 years in patients with stage 2 or stage 3 colorectal cancer after therapy, after treatment. It can also be elevated in cancers of breast, lung, ovary, prostate, and pancreas. Also can be elevated in benign conditions such as diverticulitis, peptic ulcer disease, and alcoholic cirrhosis. Alpha-fetoprotein is a glycoprotein normally produced in developing fetus. Normally levels decrease soon after birth. Elevated in primary liver cancer, meaning hepatocellular carcinoma, or germ cell tumors of the ovary and testicles. In the testicles, that is seminomatous tumors of testicles. Yolk sac tumors also produce alpha-fetoprotein. Alpha protein levels are greatly elevated in hepatocellular carcinoma, mean the median level is around 275 nanogram per ml. But even in cirrhosis is elevated, but the median levels are between 30 to 70 nanogram per ml. So in hepatocellular carcinoma, it is greatly elevated. So the current recommendation is to screen healthy hepatitis B carrier patients with annual or semi-annual measurement of alpha-fetoprotein level along with liver ultrasonography. So that is to look for hepatocellular carcinoma, because hepatocellular carcinoma is common in patients with hepatitis B carrier stage. So those hepatitis B carriers should be assessed annually or semi-annually with both alpha-fetoprotein and liver ultrasound. Benign conditions can also result in elevated AFP levels such as hepatitis, cirrhosis, pregnancy, because there is fetus produced alpha-fetoprotein, and ataxia telangiectasia. Human chorionic gonadotropin, Beta-HCG actually, an indicator of pregnancy. HCG is elevated in 90% of non-seminimatous testicular tumors. So HCG is elevated in non-seminimatous testicular tumors. Alpha-fetoprotein is elevated in seminimatous testicular tumors. It's a marker of gestational trophoblastic disease, identity-deformed mole, and choriocarcinoma. So after surgery of these for these pathologies, right, patient can be assessed periodically with beta human chorionic gonadotropin level. So ideally is to measure beta human chorionic gonadotropin weekly for 3 weeks and then monthly for at least 6 months. Right? Any increase in beta-HCG indicate the necessity for chemotherapy, because if there's an increase in human chorionic gonadotropin, that means there is recurrence, that indicates mostly chemotherapy for choriocarcinoma especially. HCG is markedly elevated in choriocarcinoma. Prostate specific antigen PSA is an androgen regulated serum protease produced by the prostatic epithelium. Normally present in the small concentration in all adult males. Blood level is elevated in patients with prostatic carcinoma and in patients with prostatitis or benign prostatic hypertrophy. So it is useful to measure the PSA levels in management of prostate cancer and even for monitoring for recurrences after treatment for prostate cancer. Chromogranin A is an acidic protein stored in adrenal medulla and other neuroendocrine tumors. So it is released with catecholamine hormones. So therefore, it can be used along with catecholamine measurement in diagnosing pheochromocytoma. Actually, chromogranin A has very high sensitivity and specificity. Is also elevated in nearly all patients with carcinoid tumors, but is not specific because it is also elevated in other neuroendocrine tumors. So because of this non-specificity, it is not used to diagnose carcinoid tumors, but you can use chromogranin A as a tumor marker in monitoring disease progression and in monitoring response to treatment. Is also elevated in patients with taking proton pump inhibitors such as omeprazole. Thyroglobulin is a glycoprotein made only by normal or abnormal thyroid tissues. Normally not released to the circulation in large amount, but serum levels increases in destructive processes such as thyroiditis, maybe overactive states such as Graves' disease and toxic multinodular goiter. The most important use of thyroglobulin is monitoring patients after treatment for thyroid cancer, because the treatment for thyroid cancer is usually total thyroidectomy or radioactive ablation of the radioactive iodine ablation of the thyroid gland. So normally after this treatment, the thyroglobulin level should be 0. So if there is any recurrence after these procedures, that the thyroglobulin becomes detectable. The undetectable thyroglobulin becomes detectable. Then it indicates, okay, the patient is getting recurrences. Then also anti-thyroglobulin antibodies can interfere with accuracy of the serum thyroglobulin levels. So the antibodies and the anti-thyroglobulin antibodies must always be tested when interpreting thyroglobulin levels. Inhibin. Inhibin is normally produced by granulosa cells of ovaries and Sertoli cells of the testis. It includes inhibin A and inhibin B. Inhibin inhibits the release of follicle-stimulating hormone from anterior pituitary. Inhibin A is a tumor marker for granulosa cell tumors of ovary. So it is used in evaluating recurrences of granulosa cell tumors, ovarian tumors. Inhibin A is also used in one of the indicators. Inhibin A is also one of the indicators used in CAD screening in aneuploidy. So in CAD screening we use maternal alpha-fetoprotein, estradiol, beta-human chorionic gonadotropin and inhibin. Inhibin is elevated in trisomy 21 Downs and decreased in trisomy 18, that is Edwards. Inhibin B is used as a marker of spermatogenesis, as a marker of fertility in males. Then we'll talk about tissue tumor markers. What are tissue tumor markers? So there are some cancers that we have the difficulty in finding the origin of carcinoma. We can't find the origin of carcinoma even after getting a thorough history, physical examination and doing all the investigations. We can't find the origin of the carcinoma. We call them as carcinoma of unknown primary. So carcinoma unknown primaries are metastatic solid tumors except hematopoietic malignancies and lymphomas for which the site of origin is not identified despite all the thorough history and the investigations. So in carcinoma of unknown primary, these tissue tumor markers are helpful in identifying the possible location of the carcinoma, possible origin of the carcinoma. So these tissue tumor markers are important in identifying possible origin of, probable origin of carcinoma of unknown primary. So we'll talk about some common tissue tumor markers. Epithelial membrane antigen, EMA, that indicates epithelial antigen, epithelial origin. If there is epithelial origin, epithelial membrane antigen is positive. If it is lymphoid origin, leukocyte common antigen, LCA is positive. If it's a melanoma, S100 or melanin or HMP45 is positive. For GI stromal tumors, CD117 is positive. GI origin tumors, Vilin is positive. If it's a breast cancer, estrogen receptor or ER progesterone receptor or HER2 receptor may be positive.